Hello, my name is Dr. Alexander Pearl, and I'm a leukemia faculty member at the Abramson Cancer Center of the University of Pennsylvania. This presentation is titled Gilteritinib in the Treatment of FLT3-mutated AML. To provide some background, FLT3 mutations activate this hematopoietic cytokine receptor in approximately one-third of patients with AML, making FLT3 the most commonly mutated gene in AML. And the most common FLT3 mutation is an internal tandem duplication, or ITD, that occurs in about a quarter of patients. This is associated with high rates of relapse and poor prognosis from low response rates to salvage chemotherapy. Additionally, about 5 to 10% of patients can have a tyrosine kinase domain, or TKD, mutation, principally at codon D835. And this is important both in terms of being another kind of activating mutation, but also one that confers resistance to certain FLT3 inhibitors. For this reason, a number of different FLT3 inhibitors have been developed. Those that target both the ITD and the TKD mutation have shown value in the clinic. I've highlighted a number of the drugs that have been so far developed to treat FLT3 ITD positive AML or FLT3 mutated AML. Here we see that they vary quite a bit in terms of their selectivity for FLT3, as you see from the red balloons on the kinome scan, each of which represents a different kinase targeted by each of these drugs. And so drugs like quizartinib, and also for gilteritinib and crenolinib, which have a similar pattern, there's greater degrees of selectivity for class 3 receptor tyrosine kinases, of which FLT3 is a member, and off-target effects are largely limited to this group of kinase targets. We also note from the table above that while these drugs are quite potent in vitro in cell culture medium, when we look at their potency in human plasma, they're really all over the map. And the more recently developed drugs, quizartinib, crenolinib, and gilteritinib, are considerably more potent in human plasma than the earlier developed drugs lustortinib, midostaurin, and sorafenib. One of the most impressive drugs to date in the second generation of FLT3 inhibitors that are both selective and potent is quizartinib. This drug has a substantial amount of activity in relapse refractory patients with FLT3 ITD mutations across a wide range of doses. However, it's notable that the drug has toxicity that's dose-dependent in terms of QT prolongation that's seen above doses of 60 milligrams a day. And also, as shown on the next slide, there's concern over the duration of response and resistance that is from on-target mutations in FLT3 that lead to reactivation of the kinase. Here we see the most common mutation is indeed D835 tyrosine kinase domain mutations, while some patients have an F691 substitution that acts like a gatekeeper mutation to impair binding of the drug to kinase target. Gilteritinib is a FLT3 inhibitor that was developed to address both the issue of toxicity and also potency and selectivity for ITD versus D835. What's different about gilteritinib is that it's a type 1 inhibitor and thus binds FLT3 kinase in both its active and inactive conformation, and this leads to a different pattern of kinase inhibition where substitutions in the kinase domain are less likely to cause resistance to gilteritinib than they are for a type 2 inhibitor such as quizartinib, where a D835 mutation clearly confers resistance to that drug. So phase 1 dose escalation testing of gilteritinib is shown on this slide, and we see that the drug is very able to inhibit FLT3 phosphorylation across a wide range of doses, but it's quite potent and quite consistent across patients on this study at doses of 80 milligrams and higher. While we did see clinical responses shown on the top right to as little as 20 milligrams of gilteritinib, these response rates were actually much more consistent and more frequent at higher doses, again those that paired with potent inhibition of the kinase as shown by the plasma inhibitory activity. We do note that the drug is active clinically in terms of responses seen in both patients with FLT3 ITD mutation and both ITD and D835 mutation, that is, the patients that are resistant to quizartinib, though they are seen in relatively small numbers on this study, and no definitive conclusions about the frequency of response can be made here. At least we know these patients do respond to the drug. There was a relatively low rate of response to patients who only had FLT3 D835, and it's not clear if this relates to the frequency of that mutation or just something about these patients. It also may reflect how the D835 mutation alone could be a weaker oncogene than the FLT3 ITD mutation. Lastly, I'd like to point out that patients who responded to gilteritinib did have, in some patients, a marked reduction in the burden of FLT3-ITD mutation in the marrow, and those patients who had at least a 2 to 3 log-fold reduction in FLT3-ITD signal compared to wild type had a markedly better survival on this study, suggesting that clearance of the FLT3-ITD mutation from the marrow could be a predictor of more durable responses to FLT3 inhibitors, and in particular to gilteritinib. So if the drug is active in the relapse refractory setting, obviously the next steps are to compare it to standard chemotherapy, which is being done on a phase 3 study that just recently completed and will be resulting quite soon, and also to bring the study to frontline therapy, which is shown on the next slide. This is a study that is being conducted to identify the optimal dose of gilteritinib in combination with frontline 7+3 chemotherapy, post-remission high-dose Ara-C, and then maintenance therapy with gilteritinib. Patients can go on to allotransplant and then return to receive maintenance therapy with gilteritinib on the study for up to 26 cycles or 2 years. And this study is currently enrolling, and we will have an update on these data at ASH 2018. The available data, however, are shown on the next slide, and they show extremely high response rates to the combination of gilteritinib plus frontline chemotherapy, with essentially all patients thus far treated who had a FLT3 mutation entering remission, though not all remissions had full count recovery. These data are very encouraging, but the number of patients treated still is relatively small, and we look forward to updates from the study that are coming soon. What do these results mean for those treating patients with FLT3-mutated AML? Well, I think gilteritinib shows that high rates of single-agent clinical response can be seen using a once-a-day oral drug. And what I haven't highlighted so much is the relative lack of toxicity of gilteritinib. I have mentioned that it was developed to decrease the likelihood of QT prolongation, and indeed that was quite rare. But indeed, patients feel quite well on this drug and have relatively modest side effects, with most of the abnormalities seen relating to cytopenias, elevation of liver function tests, elevation of muscle enzymes such as CPK or LDH, and low rates of serious GI toxicity and no significant incidence of hand-foot syndrome or other bothersome complications of other FLT3 inhibitors. This drug is active both in patients with FLT3-ITD and FLT3-D835 mutations, and as well in patients who are resistant to other FLT3 inhibitors by acquisition of D835 mutation on a background of FLT3-ITD. Now, frontline studies, as I mentioned, are ongoing to optimize the combination of gilteritinib plus intensive chemotherapy, and once that regimen is identified, it will be compared to midostaurin as the third drug added to 7 and 3 and intensive post-remission therapy. Patients in remission obviously can go on to allotransplant, and an independent study looking at post-transplant maintenance gilteritinib as compared to placebo is being conducted by the Bone Marrow Transplant Clinical Trials Network worldwide. We look forward to the results of the ADMIRAL study, which is testing single-agent gilteritinib against investigators' choice of salvage chemotherapy for first relapse of FLT3-mutated AML. We expect these data to be available soon. An interim analysis of the ADMIRAL data was used to support the new drug application for gilteritinib, which was filed in 2018. So it's possible that gilteritinib will be approved for therapy by the end of the year. Thank you for listening to this presentation.